не открывается. Спасибо. Good afternoon. My name is Irina Alexandrovna Trofimova. I am Associate Professor of Pediatric Department with the course of Children's Infectious Disease. And the topic of my lecture today is Respiratory Distress Syndrome. The term respiratory disorders reflects the presence of several non-specific symptoms in a newborn child, the appearance of which may accompany the development of numerous diseases and pathological conditions of the neonatal period, and indicate the potential presence of respiratory failure. Respiratory failure is a clinical and laboratory syndrome that is characterized by maintaining the normal gas composition of the blood due to additional respiratory efforts of the child respiratory disorders, or violation of the gas composition of the blood, hypoxemia and or hypercapnia, regardless of the nature of the external breathing of the newborn child. Diagnostic symptoms of respiratory disorders: tachypnea, respiratory rate greater than 60 per minute, bradypnea, respiratory rate less 30 per minute, dyspnea, terminal respiration, gasping type, apnea. Apnea, this is no respiration, more 20 seconds or less 20 seconds with bradycardia. Central cyanosis, cyanosis of the lips, mucous membranes, trunk. Retractions, retraction of the pliable parts of the chest. Paradoxical breathing type swing, chest sinking on exhalation and simultaneous increase in the volume of the abdomen. Expiratory noise, grunts, occur as a compensatory mechanism as a result of spasm of the glottis on exhalation, which contributes to an increase in the functional residual capacity of the lungs and prevents the decline of alveoli. And fanning wings of the nose. Not every infant with respiratory symptoms has respiratory disease. Respiratory disorders in a newborn can be caused by both pulmonary and extrapulmonary pathology. Extrapulmonary causes of respiratory disorders: they are congenital heart defects, brain and spinal cord injuries, metabolic disorder, abnormalities of the chest and diaphragm, hypovolemic or septic shock, myopathies. Pathology of the airways: malformation with airway obstruction, choanal atresia or hypoplasia, macrognathia, macroglossia, tumor of neck, congenital stenosis of the larynx, bronchi, and other. Acquired disease: swelling of the nasal mucosa, infections, and drug-induced etiology, severe acute respiratory syndrome, bacterial infection of the upper respiratory tract, and other. Pathology of the alveoli and or parenchyma of the lungs. Primary atelectasis of the lungs. Hyaline membrane disease. Meconium aspiration syndrome. Transient tachypnea, wet lungs. Pulmonary edema. Pulmonary hemorrhage. Syndromes accompanied by air escape into the chest cavity, pneumothorax, pneumomediastinum, interstitial emphysema. Pathology of the pulmonary vessels. Lung malformations. Apnea attacks. Chronic lung disease. Bronchopulmonary dysplasia. Wilson-Micketti syndrome. I highlighted the respiratory distress syndrome in red on this slide. This disease is the topic of my lecture. As you will see, the respiratory distress syndrome is one of the many causes of respiratory problem in newborns. Respiratory distress syndrome of the newborn, also called hyaline membrane disease, is the most common cause of respiratory disorders in the children in the first days of life due to primary surfactant deficiency and immature of the lungs. Incidence and severity of respiratory distress syndrome are related inversely to gestational age of newborn infant. Its occurrence is higher the lower the gestational age and body weight of the child at birth. Incidence of respiratory distress syndrome is about 85% at 28-week gestation and increases to 95% at 24-week gestation. However, by using early continuous positive airway pressure, approximately 50% of babies born at 26 to 29 weeks gestation can be managed without intubation or surfactant. The survival from respiratory distress syndrome is generally more 90%. Surfactant synthesized by type 2 alveolocytes and Clara cells. Synthesis begins in 22 to 24 week gestation. At this age, the surfactant is immature. The surfactant becomes mature at 34 weeks. Surfactant lines the alveolus from the inside with a thin layer. Surfactant consists of 90% lipids, 80% of them are phospholipids. Their main component is phosphatidylcholine, lecithin. 10% are neutral lipids. 8% of dry weight of the surfactant is made up of protein A, B, and C. This lipoprotein is released into the airways with function to decrease surface tension and maintain alveolar expansion and physiologic pressures. The main function of the surfactant prevents the alveoli from falling down on exhalation. Other function of surfactant protects the lung epithelium from damage and promotes mucociliary clearance, has bactericide activity against GR-positive bacteria, and stimulates the macrophage system of the lungs participates in the regulation of microcirculation in the lungs and the permeability of the walls of the alveoli, preventing the development of pulmonary edema. Surfactant synthesis is stimulated by glucocorticoids, thyroid hormones, estrogen, adrenaline, and noradrenaline. Surfactant synthesis is reduced. Hypothermia is less 35 degrees Celsius. Hypoxemia, acidemia, pH less 7.25 twofold decreases in synthesis. Risk factors respiratory distress syndrome: prematurity, male sex, familial predisposition, cesarean delivery without labor, perinatal asphyxia, multiple gestation, maternal diabetes, European descent, mutation in single ABCA3 gene. Pathophysiology. Surfactant deficiency is the primary cause of respiratory distress syndrome, often complicated by an overly confined chest wall. Both factors lead to progressive atelectasis and failure to develop an effective functional residual capacity. In the absence of surfactant, the small air spaces collapse. Each expiration results in progressive atelectasis. Exudative proteinaceous material and epithelial debris resulting from progressive cellular damage collect in the airway and directly decrease total lung capacity. In pathologic specimen, these material stains typically as eosinophilic hyaline membranes lining the alveolar spaces and extending into the small airways. Presence of an overly compliant chest wall. In the presence of a chest wall with weak structural support secondary to prematurity, the large negative pressures generated to open the collapsed airways cause retraction and deformation of the chest wall instead of inflation of the lungs. Decreased intrathoracic pressure. The infant with respiratory distress syndrome who is less 30 weeks gestational age often has immediately respiratory failure because of an inability to generate the intrathoracic pressure necessary to inflate the lungs without surfactant. Shunting. The presence or absence of a cardiovascular shunt through a patent ductus arteriosus and or foramen ovale may change the course of the disease. Shortly after birth, the predominant shunting is right to left across the foramen ovale into the left atrium, which may result in worsening hypoxemia. After 18 to 24 hours, left to right shunting through patent ductus arteriosus may become predominant as a result of falling pulmonary vascular resistance, leading to pulmonary edema and impaired alveolar gas exchange. In this slide, you can see normal lungs. The alveoli are open. In this slide, you can see hyaline membranes and alveolar collapse. Clinical presentation. History. The infant is often preterm or has a history of prenatal asphyxia. Infant have at birth some respiratory difficulty, which becomes progressively more severe. The classic worsening of the atelectasis seen the chest radiograph and increasing oxygen requirement for these infants have been greatly modified by exogenous surfactant therapy and effective ventilatory support. Physical examination. The first symptom, tachypnea, occurs in the first minute, the first hours of life, on a pink background. Often the presence of a light interval when this is no clinic for several hours after birth. Initial tachypnea on a pink background, cyanosis is absent. Since fetal hemoglobin has a greater affinity for oxygen, cyanosis will appear later. The infant with respiratory distress syndrome exhibits grunting. Grunting occurs when the infant partially closes the vocal cord to prolong expiration and develop or maintain some functional residual capacity. This actually improves alveolar ventilation. Nasal flaring and retraction of the chest wall. The retractions occur and increase as the infant is forced to develop high transpulmonary pressure to reinflate atelectatic air spaces. Increasing need for additional oxygenation. To assess the severity of respiratory disorders in premature infants, the Sidgerman scale is used. The parameters assessed by inspection or auscultation of the upper and lower chest and nares on a scale of 0, 1, or 2 using the system are chest movement synchronized with minimal lag or sinking of the upper chest as the abdomen rises. In the most extreme instances are seesaw-like movement of the chest and abdomen is observed and would be given a score of 2. Intercostal retractions. Retraction between the ribs is rated as none, minimal, or marked. Xiphoid retractions. Similar retraction below the xiphoid process are rated as none, minimal, or marked. Excuse me. Nasal flaring. There should be nasal flaring. Minimal flaring is scored 1 and marked flaring is scored 2. Expiratory grunting. Grunting that is audible with a stethoscope is scored 1 and grunting that is audible without using a stethoscope is scored 2. To assess the severity of respiratory disorders in full-term infant, the Down scale is used. The scale preserves the criteria, retractions and grunts, and other are included respiratory rate, cyanosis, and cry. The evaluation principle is the same as in the Silverman scale. Severity of respiratory disorders. Severe respiratory disorders, the total score is 7 points on the Downes or Silberman scale. Moderate respiratory disorder, the total score of 4 to 6 points on the scale Downes or Silberman. Mild respiratory disorders, the total score of 1 to 3 points on the scale Downes or Silberman. In other words, the higher the score, the more severe the respiratory disorders. Chest radiograph. In anteroposterior chest radiograph should be obtained for all infants with respiratory distress of any duration. The typical radiographic finding of respiratory distress syndrome is a uniform reticular granular pattern referred to as a ground glass appearance, accompanied by peripheral air bronchograms. Modern principles of providing medical care to newborn with respiratory disorders. Early identification of the problem, timely respiratory support, the use of continuous positive airway pressure as the first stage of respiratory support, always to prevent ventilators in 20 to 60% of cases. Early surfactant therapy, complex of clinical and laboratory observation, monitoring of a child receiving respiratory support. Starting method of respiratory therapy depending on gestational age. Delivery room management. In spontaneously breathing babies, stabilize with continuous positive airway pressure while mask or nasal prongs. Gentle positive pressure lung inflations should be used for persistently apneic or bradycardic infants. Intubation should be reserved for babies who have not responded to positive pressure ventilation while face mask. Babies who require intubation for stabilization should be given surfactant. Prolonged lung inflation for resuscitation of babies at birth are used with the initiation of ventilation at birth to rapidly recruit functional residual capacity and may decrease lung injury and the need for mechanical ventilation in preterm infants. Prolonged lung inflation is in extended artificial breath. It should be carried out in the first 30 seconds of life, in the absence of independent breathing, or when breathing type gasping with a pressure of 20 to 25 centimeters of water per lung for 15 to 20 seconds. At the same time, the remaining lung capacity is effectively formed in premature babies. This technique is performed once. The maneuver can be performed using a maneuver device with a T-connector or an automatic artificial lung ventilation device, which has the ability to hold the necessary pressure on inspiration for 15 to 20 seconds. It is not possible to perform prolonged lung inflation using a breathing bag. A mandatory condition for performing this maneuver is the registration of heart rate and oxygen saturation indicators by pulse oximetry. Pulse oximetry in the delivery room has three main points of application. First, continuous heart rate monitoring from the first minute of life. Prevention of hyperoxia no more than 95% at any stage of resuscitation if the child receives additional oxygen. Third, prevention of hypoxia at least 80% by 5th minutes of life and at least 85% by 10th minutes of life. Continuous positive airway pressure and nasal synchronized intermittent mandatory ventilation. Promote the creation and maintenance of lungs' functional residual capacity, prevents atelectasis, reduces respiratory function. Nasal continuous positive airway pressure, another pharyngeal continuous positive airway pressure, providing a pressure of 5 to 6 centimeters of water per lung, can be used early to delay or prevent the need for endotracheal intubation and mechanical ventilation. Criteria evaluate the effectiveness of continuous positive airway pressure. Oxygen saturation, heart rate, participation of auxiliary muscles, the dependence on oxygen. Continuous positive airway pressure treatment is recommended to be started from birth in all infants at risk of respiratory distress syndrome, such as those born at less 30 weeks gestation. Contraindications to continuous positive airway pressure therapy. Congenital malformations in a newborn, churn atresia, or other maxillofacial that prevent the correct application of nasal cannulus masks and nasopharyngeal tubes. Pneumothorax, congenital diaphragmatic hernia, bleeding, pulmonary, gastric, into the skin. And tracheal intubation and mechanical ventilation are mainstays of therapy for infants with respiratory distress syndrome in whom apnea or hypoxemia with respiratory acidosis develops. Indications for intubation. First, increase in the severity of respiratory disorders in dynamics during the first 10 to 15 minutes of life, again in the background of continuous positive airway pressure. Pronounced involvement of auxiliary muscles, assessment by Silverman score, more 3 points. 2. Need for additional oxygenation, concentration of oxygen more 50%. 3. Bradycardia, heart rate less 100 in 1 minute. 4. Ventilation in premature infants is performed for a long time, more than 5 minutes, without independent breathing. Mechanical ventilation modes include conventional modes, such as intermittent positive pressure ventilation and high frequency oscillatory ventilation. Ventilators with the capacity to synchronize respiratory effort may generate less inadvertent airway pressure and lessen barotrauma. Ventilator setting should be adjusted frequently to maintain the lowest possible pressure and inspired oxygen concentration in an attempt to minimize damage to parenchymal tissue. Volume-targeted ventilation allows patient adjusted variability in tidal volumes and winning from ventilators in accordance with the improving lung compliance. Weaning from mechanical ventilation should be started as soon as satisfactory gas exchange is achieved. Caffeine should be routinely used for very preterm neonates with respiratory distress syndrome to augment extubation. A newborn with respiratory distress syndrome needs fluid and nutritional support, antibacterial therapy, and caffeine. Surfactant therapy. Administration techniques. For prophylactic purposes, before the implementation of clinical signs of respiratory distress syndrome, newborns less 27 weeks of gestation, newborns 27 to 29 weeks, whose mothers did not receive a course of antenatal steroid prevention of respiratory distress syndrome. And second, with an early therapeutic goal, all newborns less than 32 weeks of gestation who required tracheal intubation in the delivery room due to the development of respiratory disorders. Surfactant is administered when the infant is lying supine Mechanical ventilation can be avoided by using the INSURE. There are intubate, surfactant, extubate. To continuous positive airway pressure technique when surfactant is administered. This has reduced the need for mechanical ventilation and development of bronchopulmonary dysplasia. Immediately or early extubation to non-invasive respiratory support, continuous positive airway pressure, or nasal intermittent positive pressure ventilation, following surfactant administration should be considered in otherwise stable infants. Recently, even less invasive techniques for surfactant treatment have been developed aiming for total avoidance of endotracheal intubation and mechanical ventilation. The LISA, less invasive surfactant administration method, uses a thin, flexible catheter, 5F and all catheter, which is inserted into the trachea using Magel forceps. Surfactant is administered while the spontaneously breathing infant is on nasal continuous positive airway pressure. The minimal invasive surfactant treatment method is a similar strategy wherein but stiff vascular catheter is inserted into trachea under direct laryngoscopy while the baby is on nasal continuous positive airway pressure. Curacao 200 milligram per kilo. If the qualification of medical personnel and the quality of equipment do not meet modern requirements, even the best surfactant will not help a premature baby. Supportive management, optimize fluid and nutrition management, perfusion, infection, temperature control. Prevention. Antenatal corticosteroids enhance the ripening change in the architecture of the lung and inducing enzymes. Stimulate the synthesis of phospholipids and the releases of surfactant. All pregnant women at risk of preterm loss at below 34 weeks of pregnancy should receive adrenocorticosteroids. Treatment with antenatal corticosteroids is associated with an overall reduction in neonatal death. Respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis, respiratory support, intensive care admissions, and systemic infections in the first 48 hours of life. Alternative schemes for prenatal prevention of respiratory distress syndrome. There are betamethasone 12 mg intramuscular after 24 hours, only 2 doses per course. and dexamethasone 6 mg intramuscularly every 12 hours for a total of 4 doses per course. The maximum effect of steroid therapy develops 24 hours after the start of therapy and lasts for a week. Cochrane systematic reviews are a reliable source of up-to-date, carefully selected and critically processed medical information. The logo of this medical reviews is a stylized diagram from a landmark systematic review of a meta-analysis of 7 randomized controlled trials of corticosteroids in pregnant women at risk of preterm birth. This systematic review, originally published by Crowley in 1990, influenced the introduction of this treatment into obstetric practice. This simple intervention saved millions of premature babies. Complications. Pulmonary air leaks such as pneumothorax, pneumomediastinum, pneumopericardium, and pulmonary interstitial emphysema, as well as pulmonary hemorrhage may occur. Intraventricular hemorrhage, retinopathy of prematurity. Chronic complications include respiratory problems such as bronchopulmonary dysplasia, chronic lung disease, and tracheal stenosis. We must remember that a patient who has experienced respiratory distress syndrome is a patient who has experienced an extreme condition and has functional multi-organ injuries that require rehabilitation programs and medical follow-up possible for the rest of their life. My lecture is over. I can answer on your question.